you have the pump, and then it goes back to the aorta. And one of the things we learned... You fainted in the past, over the last couple of years? Do you faint?
Oh, yeah. Well, I just fall down without any warning. I'd be walking in the street merrily along the way, and then I'm on the floor. Okay.
How many times has that happened?
Must have happened 6 times or so.
Did you know you were going down, or you had no warning?
No warning.
So this is really true syncope.
What is it?
Fainting.
Oh, yeah.
You're fainting. We have to figure out why. You may have many reasons to faint. Dr. Fuster and I make rounds the old-fashioned way. We were trained to go to the bedside and talk to the patients, and take the perfect history and do the perfect physical, from which one ought to be able to make a diagnosis or come close to a diagnosis maybe 90% of the time. And we thought that doctors don't do that anymore. They sit at computers and they type in stuff and they fill in templates and so on. Open your eyes. And so we thought that we could teach others how to go to the bedside and take care of people. Sometimes when you do these, it's called frontal release signs. You all know that. You tap on the nose or you tap on the forehead, the eyes blink. That's consistent with PD. Well, look, we're going to look at your heart and see what vessels are blocked, if any. We don't know yet. Mm-hmm. And then we're going to have to take care of your fainting. So you're going to take care of the diabetes, and we'll take care of your fainting. How's that?
Well, that's a deal.
Is that a deal?
Good deal.
When did you begin to feel that something was wrong?
Well, 4 years ago, I began to feel that something was wrong, but that I was having difficulty walking and that I was collapsing in various ways. And then on Saturday, I could no longer even get a piece of bread out of the...
Really? Did you have chest pain?
No pain.
Nothing?
Just that I was just absolutely wiped out.
Dr. Sklerov and I began to make rounds together maybe 10 years ago.
Well, we'll see.
We both have the philosophy that the number one objective in medicine is the patient. And we both believe that most of what you learn about a particular patient is at the bedside, not with machines. The training programs today are very short, so you have to learn a lot of technology over a short period of time. And this makes these young fellows, or interns and residents, less well-trained in terms of their relationship with the patient. We should be training people more and more how to pay attention to the patient.
So this is a new admission. He's an 83-year-old man. He has a history of non-insulin dependent diabetes with an A1C of 6.3 on metformin only, and hypertension and asthma. So yesterday morning he was eating breakfast. He had the sudden onset of this substernal chest pressure. He was describing it as a lot of heaviness. Took himself to the urgent care clinic where they saw some sort of non-specific changes in his EKG and sent him to the emergency room, even though he clinically looked fairly well. So on his EKG, he initially had some changes in the inferolateral leads, which sort of changed over time also. T-wave inversions became more marked. He was started on a heparin drip, and he was receiving nitroglycerin drip as well, but the pain was ongoing. So we brought him here for further management. The cath showed triple vessel disease, left main disease. He was recommended for cabbage, which will hopefully happen tomorrow.
Long-standing asthma?
Frankly, I didn't ask. I didn't ask when he was diagnosed.
The cardiogram shows long-standing asthma.
Yeah.
There's no voltage. And a guy like this at his age, and there's very scant voltage, so you have to figure out why. I mean, it's unusual, but he makes, there's only 5 in the standard leads, and so maybe that's asthmatic, and maybe he's got emphysema. Do we have a chest x-ray? His diaphragms are really down. And there's air between the diaphragm and the heart on the left. But we can examine to see if he's got emphysema or asthma or wheezing or something.
Okay, shall we go and see?
Good morning. I'm Dr. Sklarov. This is Professor Fuster.
Hello?
Hi. Can we ask you some questions?
Sure, please.
Did you ever smoke cigarettes?
No, I'm a pipe smoker.
Oh, 2 pipes a day, pipefuls
Yeah,
a day?
2 pipes a day. Was, as of yesterday, no more.
Tell us about the asthma. You have asthma?
I'm in here for my heart.
No, I know that, but in the past.
I have asthma, yes.
How long time?
Yeah, as a child. Went away for about 25 years. Then it came back slowly.
So what do you take for your asthma? I know.
Advir, you know that, Advir. They're very effective.
It prevents it?
Yeah, it's good. It's good. I couldn't go into cold air. Now I can.
Hear the resonance? That's real. That shouldn't be. That should be flat. Absence of liver dullness of the diaphragms. Now we'll talk about your heart. When did this come, this chest pain?
I'm not sure.
A couple of days ago, weeks ago?
I'm not sure because it was too diffused. Too diffused. So I would say it could have started, speaking of doctors, it could have started 4 weeks ago. It got all messed up because I had this H. pyloric intestinal thing that threw me for about 3 months. And so the merging of the two has made me unsure as to really when the heart business began to
Did you have heartburn?
No.
How did you know you had H. pylori?
Constipation and gas.
That was the manifestation?
Yes. I went for so many examinations, MRIs, everything came back. Healthiest guy in the world. You're looking at the healthiest guy in the world who's facing
So you recently had all this stuff here and it was unclear whether it was the heart or the GI. Did you have an endoscopy?
Yes.
And?
Nothing.
So why are you treating for the H. pylori? They found H. pylori just
Eventually,
routinely?
yes. You know how they do it.
So that was a routine test.
That's
looking
right.
for the cause of your discomfort.
Absolutely.
So in retrospect, it was cardiac discomfort all the time, and they went through all the motions, and finally it eventuated into a Q-wave infarct in the diaphragmatic leads. Take a deep breath. Let it go. Now relax. Now take a deep breath. Let it go. Just turn this so you can see the neck veins right to here. Head back. There are 2 bruits, right and left. High up. So you're going to have a bypass tomorrow, I understand?
Changes my life, right?
No, it's...
Doesn't?
No, you're going to be operated on, and a guy like you is looking so well, you'll waltz out of there.
I can keep drinking my scotch?
Absolutely. Open your mouth, take a deep breath in and blow out on my hand like this. Don't purse your lips. Watch me. Significant. Now, so I think he has COPD, asthma, coronary disease, bilateral carotids, not significant diabetes. You're going to do beautifully.
Thank you for the good message.
Yes, no question. See you.
Thank you.
I mean, this is an example of a guy who runs around all over and gets endoscopy and he gets H. pylori. It's got nothing to do with anything. It has MRIs, a huge workup. And in the diabetic, now maybe it's because the pain was so atypical in the diabetic that they didn't zero in right away on the coronaries. But look at all you can learn. Positive match test, positive chest x-ray, COPD, all the rest, just at the bedside.
Okay, what do we have here?
So she is a 67-year-old woman. History of very bad ischemic coronary disease. She has multivessel disease. She had a cabbage about 5 years ago. And she's had approximately 13 stents at various hospitals, mostly post-cabbage.
So, excuse me, how many?
13.
Stents?
Yeah.
He is very efficient, the cath lab. You don't breathe and this patient is already there. One of the problems in the culture is that you have things available and you use them, but you still don't have the right question of why you use them. If there's any message we can give to you, be sure you don't do something just because you have technology available. Technology is available, but your heads should be also available.
I always did stuff the hard way. It always was like that, always. But I was hard-headed, and I was a child. When I first got diagnosed, I was 19. I'm still a child now. I'm 22.
And what gives you the strength to keep going on?
You want me to cry, don't you? I have 2 boys.
They're adorable.
And sometimes I feel like even there is people there, but there's not a lot of people there for me. So I feel like I have nobody. So if I feel like I have nobody, if I'm dead and gone, my kid's gonna have completely nobody.
Okay, so what do we have here?
So this is a new admission for Miss J in bed 5. So her chief complaint was that her ICD discharged. So her story, she's a 22-year-old female. She's from upstate New York. She's status post AICD placement and LVAD placement in August. She's on the transplant list. Also has atrial fibrillation on Coumadin. So she was in her usual state of health since her last discharge from Mount Sinai, which was in September, after coming in for the LVAD placement. She'd been doing well for the last 3 months until about a week ago when her ICD fired. She went into the hospital in Buffalo. They basically interrogated it, didn't think that there was anything abnormal with it, repleted her electrolytes and sent her home. On Tuesday, she woke up, was just watching TV, started to feel a little bit weak, a little bit of palpitations, and at that point her ICD fired again. So she went to the emergency room, and in the emergency room in Buffalo, her ICD fired 2 more times. She was found to be in non-sustained monomorphic VTAC, and they started her on a lidocaine drip. At that point, she was transferred to us last night.
Hi. How are you? So we understand that you got this heart disease during your pregnancy or after your pregnancy?
Yeah, after.
Afterwards.
Yeah. Well, he was born in February, and I got diagnosed in May.
That was your first child?
No, second.
Second. Did you have this after your first child?
After the first one, I had some difficulties, but they couldn't figure out what it was, so.
What was the difficulty after the first birth?
Well, I was short of breath. I passed out a couple of times.
After
during
the first
activities.
So your activities were limited, you were short. So after the first child, she was already in trouble. And they didn't understand at the time what was the trouble was? Is that the idea?
And I had a regular heartbeat, but they didn't know what it was.
So you had an irregular heartbeat, you were short of breath, all after the first child. And then you get a second pregnancy. And so the myocardiopathy was there the first time, and then the second pregnancy really does it.
Were you told after the first pregnancy of the dangers of a second pregnancy, or nobody knew?
No, they didn't know what was wrong.
I see. When you the cardiomyopathy in pregnancy, 75% continue to have left ventricular dysfunction. And the 25% that they recover, 50% they have a recurrence after the second pregnancy. But if you did not recover, the chances of getting worse are high on the second pregnancy.
And so now we're going to take care of you, give you a new heart and make you feel better.
Yeah.
That's the plan.
Yeah, I bumped up on the list.
Yeah, you're 1A?
Yeah.
That's wonderful.
Can I see that just for a second? You know, one of the problems is I don't see the venous pressure here. And I will never leave seeing a patient without seeing the venous pressure. So how do you do it? I don't see it. It's too low, maybe. Diuretics?
No, you don't take any diuretics, do you? Right now?
Aldactone.
Oh, aldactone, yeah. That's fairly new. We had the medication list in front of us. He didn't. And he kind of knew she was getting these medications. That's pretty powerful, I think. That's what I remember, mostly because I was wrong. You tend to remember the things when you're way off. But that's what stuck with me, that he could pick out the presence of these medications simply by physical exam.
So, because this may be relatively volume depleted, that's what I'm asking you. You don't see the venous pressure. The first thing to ask is if there is a diuretic. So what you do, excuse me for that. Thank you very much. Thank you. Are you okay?
Mm-hmm.
Yeah. You stay like that. The venous pressure is here. It's actually below the clavicle. I see very, very barely here. You see that? It's at this level. And then when you pull her up, you don't see it because it's just too low. The venous pressure is always the same. It depends the position of the patient. You see it or you don't. Here you see? You don't see it. It's too low. It's below the clavicle. You know, if I am like this and I have a venous pressure that is like this, if you put me like this, you see, then you see it. The vertical is the same. So the venous pressure is very critical, and you never leave the bedside without knowing what is the venous pressure, because it's much more accurate than any echocardiogram or any technology that you can use, right? Thanks very much for giving us the opportunity to say a few things. Okay.
You're welcome.
It's a pleasure.
Thank you.
The best luck to you.
Thank you.
Good.
See you later.
See you later.
She's a very spirited person.
Yeah.
She's wonderful. Yeah.
Yeah. So she's had a tough life.
Sure.
And they missed the diagnosis, unfortunately, with the first pregnancy.
Yeah.
She was sick right away, and whatever it was, it fell through the cracks. And
She
then
would
this
have
is
avoided the second.
I was 3 days just coming out of the hospital. And I don't want to come back because when I fell into my bed, I deep sleep. And my body's tired. I've been in the hospital for a couple of months now.
Okay, so here.
So bed 4 is a new admission from this morning. He's a 51-year-old male, and the chief complaint is weakness. Past medical history of non-ischemic cardiomyopathy. So he's been in and out of the hospital pretty consistently for about the last 2 months. He's been admitted several times in November and December to the hospital. They said that because of his worsening kidney failure and his worsening cardiac function, that he was not going to be a candidate for an LVAD or an ICD. So they offered him amiodarone, and he refused it.
You say the patient is not a candidate? Why?
Yeah, so it's kind of unclear to us. In the transfer note from the hospital, basically just said because his renal function was worsening so much that they didn't think he'd be able to tolerate a procedure. There's also, he had a UTOX, which was positive for cocaine, so we weren't sure if that may have played a role. So he was discharged home last Friday. And then last night, the sister found him lying in bed, was having trouble arousing him. He was shaking. So at that point, she called 911. He was brought into the hospital.
How do you feel now?
Well, actually, the problem was they gave me a medication a couple of days ago, which was so strong that my body couldn't tolerate it. So it was the palpitation, and I couldn't breathe. And that's what caused me to be in the hospital.
I see. Excuse me, I'm sorry, my friend. Can I see you, friend?
Yes.
You don't mind. Things are pulsatile liver. So low cardiac output, high venous pressure, low proteins probably. Palpable right ventricle, very diffuse, palpable left ventricle, gallop rhythm, and low output. So I think you got the picture.
We'll get you better.
Nice to meet you.
I thank you, Doc.
Let's try.
I thank you all.
So let me ask you, were he not, let's assume he has a bad rap with the cocaine, and the only reason not to put in an LVAD is because he has all the, cocaine, he's unreliable or whatever. But the question is that valid? Because if he doesn't have an LVAD, he's got no future. He may have no future anyway.
I think it's nice he came here as a new look.
Yeah.
And start fresh from zero. I agree. Yeah.
I really have to emphasize that these LVADs and the subsequent transplantation is not something that is routine at all. And a very thorough evaluation is done of the patient's background, the patient's social fabric, the support structure that is available afterwards, the ability to get to a hospital or communicate with your doctor right away, the ability to care for the device so that there are no complications.
This is the pump right there. So it's just like having a heart transplant, when instead of giving you a heart, they give you this LVAD. Before I was diagnosed in May, I went to the hospital in Buffalo, New York, and I thought I had bronchitis. So I told them that. They just swabbed my mouth and said, you have a common cold, and told me to go home. Yeah. So a month later, I still had the same symptoms. So I went to a different hospital. I went to Sisters Hospital. And they did a whole bunch of tests, and they told me I have heart failure, cardiomyopathy heart failure. So they told me, okay, well, you need a heart transplant. We need you to go to a different hospital. I went to the hospital. And being that I got this news, I'm angry. I was mad. They would tell me what to do, and, like, if I was to get mad, I'm still listening to them. But when I get mad and they are saying something I just mad to hear about, I would, like, just sit there and roll my eyes and I would listen, and I probably won't even look at them. They didn't like my attitude. So they denied me for a heart transplant and a heart pump. I'm like, y'all just gonna let me die? I'm 19 years old, y'all just gonna let me die? Time is running out, and now I'm starting to feel weaker, so it's like, what am I gonna do? So then that's when I started looking online for more hospitals. Try every hospital in New York State if you have to, and that's what I was gonna do.
Yeah, but if we do a trick, we're going to call you again and get your consent, you understand? We don't do anything without a consent. We need you to understand and agree. Perfect. Perfect.
How many patients we have today?
We have about 9. We're going to probably fill it today.
When I go to an emergency room in 2000, one of the doctors told me and my husband that he cannot bring me all the time with the same episodes. If I listen to them, I be dead. I get mad. My husband wants to push the doctor and everything. I say, no, this is the way that I feel. My leg and everything, all the system in my right side.
So this is a new admission. Chief complaint is chest pain. So she's a 55-year-old female, has a history of diabetes, hypertension, hyperlipidemia, 10-pack year history of smoking, and also off all of her meds for 2 years, all meds. On the day of admission, she was sitting in bed and passed out, no prodrome, no shaking, no loss of bowel or bladder. She actually reports a similar incident that was leading to her stents back in 2000. Very similar incident. She was lying in bed, she sat up, suddenly passed out, fell forward, went to the hospital. So when she came to the ED, she had a stress test. It showed a moderate anterior perfusion abnormality.
When? When was the stress test?
Yesterday.
She
Yesterday prior to cath.
With this story, she had a stress test?
I know.
Okay.
So she then received cath, and she was found to have 2-vessel disease. Would you like to see the cath report?
She had a mid-LAD, 70 to 80%. And then she had subtotal occlusion of D1. And the proximal RCA was 90 to 95%. So it was considered a culprit lesion, was the mid-LAD. That's what it is. Interesting.
This story does not fit.
I agree.
She has multiple syncope, and every time she gets something wrong with her, whether it's the right in the right chest and not. And so it's so confusing. I mean, she doesn't have that kind of disease to give you a syncope in V-tach. And besides, she recovers so quickly. So there's something not right.
It's extremely important, not only the examination of the patient, physical exam, but the talking with the patient to understand the facts. What machine is going to tell you why this patient passed out? You have to talk to the patient. What were you doing? Were you standing up? Were you getting out of bed at night to pass urine where you can have a spell of syncope passing out? All of this is communication with the patient. Let me ask you, what happened recently with the chest pains? Was something new?
No. I feel the same system like the first time in 2000, 2002.
When did you start having chest pains recently? When?
Sunday.
Sunday? Can you tell us what was with exertion, changing position? What was?
No. The pain started in my right side, the pain in my arm, then come up to my neck, then I feel it in the side on my chest. And Thursday when I came was the worst because I feel the pain in the middle of my chest and the headache.
Can I ask you, did you have any discomfort walking?
Yes.
So,
pain, but like I said, in the right side and not in the middle, just in the side.
Yeah, but you know, we are more interested into what caused the pain. Was exertion?
No, that doesn't matter if I'm sitting down, watching TV, I feel the same pain in my side. When they start, they start. It doesn't matter if I'm doing something hard or doing something in the kitchen. No, I'm been sitting down when
Did it wake you up at night?
It. Yes.
It did?
Yeah.
You woke up with pain?
Yeah, with that.
How long these episodes lasted?
Como 3 minutes.
And did you pass out? Were you there? I think apparently she passed out at home. What happened?
She's complaining about chest pains.
Yeah.
I went to get her some water, and when I came back, she was passed out on the bed.
Yeah.
And since she said she had chest pains, I didn't want to put no pressure on her chest. I just tried to wake up. She didn't wake up, so I gave her CPR, mouth to mouth, and she reacted.
This could be vasovagal, actually. Who knows what it was. Somebody can ask us why we check the femorals and radials at the same time. We always do that, you know, because you have two things. One, if the patient has hypertension, be sure there is no coarctation. You say, well, coarctation is quite rare. Doesn't matter if you always do the same thing. And the second, if the pulses are decreased in the legs, could be related to peripheral vascular disease. So you do both things. The question I have here is I don't feel the pulses well. Now I do, you know. You have never, on a physical exam, you have never to give up. You have to, the pulses are present. The other thing is the left upper quadrant is where the abdominal aortic aneurysms can be detected. So you always have to stop breathing. You put the hands in the left upper quadrant and breathe normally. Take a deep breath in, out, in. Actually, in the last 2 weeks, Dr. Castellano is not here. In the last 2 weeks, we saw 2 patients that just by feeling the left upper quadrant, the aorta was dilated and actually were aneurysms. Just 2, detected by just palpation.
Can you lie down for a second? Where is this pain when it starts on the right side?
On the right side?
Yeah.
First in the side.
Okay.
And Thursday when I came, in the middle.
Now when I push here, does it bother you?
Machucado negro.
bruised?
Bruise, like when you bruise and you touch and there's...
Does that bother you here?
Yeah.
Is that the pain you're talking about?
No.
I'm just hurting you.
I know.
But I'm
Not
not making the pain.
No.
When trying to elicit is chest wall syndrome and costochondritis, and Dr. Fuster alluded to vasovagal syncope. There's a dictum, patients with atherosclerotic disease come up with syncope, so it's VT till proved otherwise, because that's how you have to think. But this is not the case. It's so atypical. And then she has a negative stress test. If you have a negative stress test, the predictability of bad outcome is, the outcome is very good with a negative stress test. And she has an old stent, so we don't know if that's an old defect, even. So this is so complicated.
Yeah, certainly the ischemia didn't appear to be in the right system. It was in the left, at least according to the perfusion.
Okay, but the point is that never, when I feel sick before, when my first stent, I never feel the pain in the left side. Always goes
on the
in
right
my
side.
right side.
That's a good point. We won't forget that.
Okay.
Let's assume that the angina was coming from the right coronary artery, and that's associated with bradycardia and syncope. This is atypical chest pain. I mean, whatever it is, it's a diabetic patient and female. That combination is often atypical chest pain seen in CAD. And you have to think that way because she has CAD and diabetes, and every risk factor known. So it probably is atypical chest pain in a diabetic from coronary disease. But I would be loath with all this information to take her to the operating room.
Yeah, there are too many questions, which is what you're saying.
Yes.
I'm just curious to see this angiogram. They put a stent there, and then you put a stent here. You see that? This is pretty significant here. Yeah, you see that?
It'd be of interest when they go after the right coronary, when they put the balloon in there, whether or not she doesn't Brady down and get, vasovagal in the right coronary system. I would.
You're making a good point.
If I had a patient who faints from coronary disease and it isn't VT, it's the right coronary artery and vasovagal and bradycardic. And so the follow-up is beautiful because you put a balloon in there and you simulate the ischemia, and then she suddenly drops the pressure, you got a diagnosis.
In fact, I would bet that you're right. That the problem in this patient was a culprit right RCA, not the left system. But the left system, the stress test led people to go to the left. That appears to me quite significant, isn't it? And I can imagine this. You see, it's almost closed. I can imagine having chest pain from time to time, which is not quite typical. I think they went into the wrong system. So you are right again, my friend.
I would get on with it. I wouldn't set this lady home with a lesion like that.
I can agree with you. This is the culprit, is the right RCA. Anyway, this is a good case for discussion.
Every time that I come to emergency room, I've been consistent. This is what I feel. It's in my right side, never in the left side. Never, nothing in the left side. If I feel sick and I'm telling you, this is what I feel, why you say no? Oh, but that's sugar, that she feel this, this. Why they think I'm stupid? They have to listen to people when they come to emergency. Not treat people like you're a liar.
All right, so this is a 102-year-old female with history of CHF.
She's 102 years old.
102 years old. She had not gone to a doctor in a number of years, so that's what it seems
That's why she's
like.
102.
Exactly, that's why she made it.
She got there by herself. Let's not do too much.
I hear 3 sounds.
Right.
3 extra sounds. There's no question it's a gallop. You should listen because it's it's like a train.
Open your mouth. So when you see a narrow orifice, the tongue, and a narrow oropharyngeal there, well, this patient probably has sleep apnea.
Yeah, so can we push?
Push the lever. I would do it more lateral here. You see now? It's coming up.
Yep.
Here. So this is a vein. Now you have a challenge here. This patient had significant angina and has been treated medically. My question to you, what is medical treatment that you're going to help him with?
Yeah, so if we can go up on his beta blocker.
Be careful at this age by going up with beta blocker. Beta blockers are very easy to talk about, but they get into your head. Fatigue. I don't feel as well as before. I don't sleep as before. I dream at night, and we don't care. We should care. And that is, it's easy to give beta blockers to everybody around it, but I'm quite in agreement. A diuretic, if you accept having to pee a few more times a day, which is you have to tell the patient, is much better than feeling lousy. Particularly as the patients get older, and I go beyond beta blockers, even statins that we distribute all over, their side effects are never on the trials because the trials don't look for subtle things, whether you sleep well or not, and you realize that the statins, can affect you. So we have to be very careful with any drug we give because we have to be, side effects are very, very common.
No, it's 20% of all illnesses caused by medicines.
I would say more than 20%.
Yeah, so it's a huge number.
Stop drugs on things that are subtle. Is that right?
I couldn't agree more. I make a living on stopping medicines.
All right, so if you're okay with it, we'd like to go ahead and put the balloon pump in later today so that we can give this, give your heart a boost, if it will.
Can I think about it?
Yeah, sure, you can think about it. Like I said, if you don't do it, we're still going to, make adjustments to your medications. We're going to start a drip to get some of the fluid off, a Lasix drip. And we'll, do a few other things to see if we can help you out. So why don't you think about it? I'll be back in maybe an hour or two. Okay? All right.
Where do we stand with this patient?
As far as the overall plan with him, he's refusing any further therapies, and the heart failure team wanted to put a swan in him, but he was refusing, and his sister, who's supposed to be his healthcare proxy, didn't want it because he didn't want it.
He feels that the medications are causing him to have the leg swelling and all of the symptoms that he's having, instead of understanding that his heart condition, his heart failure is worsening, and he needs the medications because he can't survive without them at this point.
Yesterday he wanted all his drips stopped. But when I explained to him that he needs the drips to keep his blood pressure high enough to live, he says that he doesn't need them, and that his blood pressure will be fine, and that he'll do okay.
Yeah, but we know that he's not.
Right, yeah.
So from my understanding, they're going to do a formal assessment, whether he's a candidate or not, again, for an LVAD.
Do you think the major interference is a psychological state rather than his so-called cognitive state? That is, he's intelligent, but he's psychologically damaged. Is that right? So that's the major impediment in his care.
Mm-hmm. Yeah. His whole goal is to go home so that he can enjoy a quality of life.
Exactly. So, but he's not saying to us at all that he's ready not to go.
Right. Exactly.
So let's tell him that he's a candidate for LVAD. It's the only way to save his life. And if we can just tide him over until the LVAD decision is made, he doesn't want to jeopardize himself any further, but you have to lay it on the line. So let's keep talking. Is he fibrillating?
He's in sinus tach.
Always sinus tach?
Occasional NSVT overnight.
But this is drug-induced tachycardia.
He's on 5-adrenaline, 5 in Milrinone, or 0.5 in Milrinone.
Midodrine?
Is that Midodrine?
He's a young guy. He's a really young guy who has been very independent, very active. We know that he's an accountant, he's well-educated, went to Pace University. He was a runner before all of this started happening. So, all of a sudden you go from being independent and functioning to having to make decisions that maybe you weren't quite ready to make yet. You think that, I have plenty of time to worry about that stuff later, 20 years from now.
Yesterday they do the stent, put in the medication and everything. Yeah, that helped me a lot. And I feel much better, much better. So I promise myself and the doctor that I'm gonna drink all my medications, but I don't promise that I'm gonna drink 15 medicine like always. all the time. But if they two in one day and one the night, I only want to drink one.
Okay, so what's happening?
So basically, yesterday she went for repeat cath. They showed, again, a tight lesion in her proximal RCA. They opened it up. They placed a drug-eluting stent. She felt much better when she came back.
Sure.
She was chest pain-free, no dyspnea, feeling well all day, essentially.
This is truly spectacular.
She had pain when they did when they expand the stent. Do you know?
That I don't know.
Well, we can ask her.
So you feel happier?
I feel good now.
Did you have chest pain when they did that procedure, when they opened the artery? Did you have discomfort?
Yeah, discomfort. Not pain, not discomfort.
Discomfort
Yeah.
was similar to the discomfort you had that brought you here?
Yeah.
Very similar.
Yeah, very
This was
similar.
when they put it
They
there.
got- yeah.
So which really proves the concept that that's the reason why it. Well, that's good. We all feel better. Now you are all fixed.
She's planning to go home today. We have a lot of work to do in terms of medical therapy, and I emphasized to her that she has to take her medications.
See, this is a patient. You stopped your medicines for 2 years.
Yeah.
Hey, we spoke about that.
My friends, this has to be done properly. This requires not just let's see somebody to follow. This requires a phone call to somebody that you really know who is the person. Your diabetes has to be treated.
Yeah.
Otherwise, you're going to be back.
I know.
Okay? So I would refer her to the diabetes group here.
Okay.
This is serious. This is where your next few years depend from, how you take care of this, of the diabetes, okay? Good. Nice to meet you.
Okay, nice to meet you
good,
too.
Good.
Thank you.
See you.
Bye-bye.
This is a non-compliant patient, which requires a very obsessive doctor. And that's the reality. Otherwise, what we do here is cosmetic. She would come back. It's probably as important as the admission of the patient to the unit. It's how you discharge the patient.
Ryan, thanks a lot.
My parents are taking care of me, and we have a weird sense of humor, and they'll ask me to do something. I'll say, well, I've had a heart attack, so I can't possibly do whatever you want me to do.
Tell what was the reason for this?
Oh, she had a spontaneous coronary,
How old is she?
45, history of hypertension. So she had a spontaneous coronary artery dissection. At the time, it was thought the desire was to work her up for a possible fibromuscular dysplasia.
Sure.
She had renal artery ultrasounds ordered as well as carotid Dopplers. The problem was prior to receiving the studies, she very much wanted to go home, get the studies as an outpatient, and then present it again.
And she didn't
the
have
same
any other
presentation.
problem before, anywhere.
So she presented again yesterday with chest pain times 1 day. Pain was of the same character as her first presentation. She was taken to the cath lab, found to have another coronary dissection distal to the prior lesion. She received PTCA as well as a drug-eluting stent to the lesion, was then admitted to ADS after the procedure.
So we have one dissection a week ago.
Yes.
Then we have a second dissection distal to the
Yes.
stent, which was stented.
Yes.
So now we got 2 stents. Then she has subsequent pain after the deployment of the stent.
Yes.
That abated with increase in nitro.
this is the
That's the
third
story.
time.
This is now the third time.
And the third time, they couldn't find a dissection.
So the third time they didn't take her back to the cath lab.
I see.
Yes.
So this is unusual, no? To say the least. How are you feeling?
I'm feeling better than I felt last night.
No pain anymore?
Not right now, no.
And you never had any trouble walking down the street with chest pain? This happened out of the blue, this chest pain.
Correct.
Was this chest pain similar to the one you had
A week
the
ago?
first time? Yeah.
Yeah. It comes on suddenly, and just the pressure just keeps getting more and more and more intense. And then the chest pain is more like a little bit of a rising, burning sensation.
You said that your discomfort arose in the left.
It starts here.
You didn't see anything, you just felt it there.
Nobody's seen anything, you just feel it.
Are you double jointed?
No.
Do this. Wrap your fingers around.
Do that.
This is a very important finding at the bedside. You see what she does. If I go like this, but there's a space there. So that is very much morphinoid, or it could be, as you know. So we ought to do some genetic testing, because that's a real finding. Just looking at the hand and showing that there are 100 diseases that you can see by looking at the hands. So you can go to the bedside, and there are many signs at the bedside. Which give you clues. They're called bedside clues to the diseases of the heart. And they can change your thinking. Because then you say, oh, this patient has this disease, therefore we can't do this, we can't do that, or we should do more, and so on. So we always look at the hands. And you do it just by holding the patient's hands and looking. In other words, you can look. It takes you a second, while you're doing everything else. So it doesn't take any time. Yeah, so there are exciting things you can learn. And everybody's astonished, They say, oh, my God, we missed it, and something like that. It's positive. There's a little bruise, grade 1, in the carotids.
Can I see your throat just for a second? Can you open your mouth?
She has a pallus torus,
Yeah. Nobody in the family had any problem like this?
Actually, I had an aunt that passed away at 50. At the time, they didn't die. It was from cardiac.
Well, we'll talk to your doctor and so forth, okay?
Thank you.
Nice to meet you.
Listen, this is very distressing for the parents. You should know. You're obviously...
Well, my sister just said that.
Anyway, we're going to look at every blood vessel here and be very careful with her. Okay? But we understand the problems. So she may have a little bit of that because of this business.
Thank you.
Okay. And you have Dr. Wen as your doctor, so she knows what to do. Her aunt was morphinoid. She was very tall and had a sudden death. So this is a familial issue.
It's elastic tissue disorder, yeah.
This is frightening. And this mother is scared to death because she knows what happened to her sister and now her daughter, and twice, and dissections and so on.
It's pacing more than it has.
Than what it was at 40.
Right. But they say the 40 heart rate is too low. They want it higher.
And I don't understand how it's too low when they said it don't matter if it's low or high because you have the LVAD, nothing's going to happen to you. So what is the point?
You still have to tell them how you feel.
It feels like my heart is going to keep going up and my heart is going to bust. It feels like my heart is going to bust. It feels like a balloon is being pressured, is being blown up, and after a while is going to bust. That's what it feels like.
They know what they're doing.
Okay, they could know what they're doing, but that ain't going to stop me from talking either. And telling them how I'm feeling. Because at the end of the day, it's not their body, it's mine. They don't have to feel this. They go home every night and get some peaceful sleep.
What's happening in bed 4?
We're basically just diuresing him and trying to slowly wean his pressors off, his vasopressins, so that he can be transferred to the floor. Those are short-term goals, but the long-term goals we're still working on.
I love what you say. Now you are speaking real. Short-term and long-term. Good.
So yesterday, palliative care was consulted. They're going to see him today, and psych was also consulted yesterday.
He's still being non-compliant, and the team wanted to get a better understanding from the sister what kind of person he is, and his sister did agree with us in that, he is very difficult, he is very independent, and he can be very stubborn. So she feels that that is part of what's playing into all of this, and she doesn't necessarily agree that maybe he's not understanding what's going on.
He kind of refuses to accept how sick he is, but he has a strong sense of miracles can happen, and if We only should get him to a point where he can go home. He'll be able to handle it, the rest of the way.
What do you do with the patient who doesn't listen to you? Or what do you do with the patient who says no, even though he should say yes? And how do we interact with such a patient? You're going to encounter patients like that, and the relationship between the doctor and the patient is dicey. And the question is, do you abandon the patient? How do you handle such a patient, which is an art? But be very careful about criticizing the patient and coming down on him and abandoning such a patient, because he's a human being and he suffers, even though, so.
If you put an LVAD, he will not make it. I can tell you, this is the typical individual that you do a procedure against the will, which you should never do. Yeah. And they don't make it for lots of reasons. I mean, do you know the cost of this? On a guy who doesn't want to have it? I mean, it's not going to last a few days. This guy has been against everything conceivable thing we have been telling him from day number one. How is he going to be compliant?
This fellow does not want to die. You have to know that. I talked to him this morning. And, I mean, that's out of the equation as far as he's concerned at the moment. He talked to me about equities and accounting and so on. So it's interested in the psychiatrist, but remember, this guy does not want to die. I realize the complexity and I realize the monetary constraints and all of that business, but he doesn't want to die. And so I don't know what else to do, but without an LVAD, he's doomed. So we'll see what they say when the LVAD decision is made. They will not be enthusiastic.
I sat down with him for quite a while. I talked to him, and one of the things that kind of came out of it was that, if he was a candidate for the LVAD, he has nobody at home to help care for that with him. And, he's got grown children who he doesn't want to interfere with their lives. And he has a sister who's his health care proxy that lives in Maryland, and he's not willing to move down there, and it sounds like she's probably not able to come up here and help him take care. And maybe he's trying to tell us that he's not a candidate for the LVAD without us even saying it to him.
Everybody keep on coming in here and saying, oh, we're going to do this. They're not telling me why they're going to do it, so no, I'm not going to let you do it.
The lead has to be repositioned. The lead is not good. That means it's not that normally people don't feel it, and you're feeling it. That for me means your lead has to be repositioned. Okay.
So they have to do the pacer over. They have to do this over.
It's a simple incision. Just you open it up and then take the lead, reposition it, and then fix it to close it. That's it. So that may need to be done. Okay. Then that will be the cure for that.
But didn't they do that when I had surgery?
LVAD surgery? No, we didn't do that.
Currently, she is possibly going for a lead replacement today. And her INR's still been subtherapeutic despite increasing her Coumadin dosing, so she's still on her heparin drip currently. But other than that, she's doing well.
Nothing else to say. We just wait and wait for the heart.
Yeah.
She's psychologically holding it together.
Yeah. Yeah.
Don't let nobody take my rolls. Your rolls?
Yeah. No, I don't take your rolls.
I never realized how strong she was until now. She's very strong, and she's developing, and she's growing better as a person. Her character is a lot better in this tragic situation. I think people really don't know how strong they are until stuff like this start to happen to them. Because I know some people are like, I wouldn't be able to do it. I won't be able to. Yeah, you would. You ain't got no choice to do it. Yeah, I do need a hurt. But that's somebody dying for it. So it'll come when it comes.
Is that what you're looking for? No, this one. This is, I don't even know what that is up there.
Well, I just took my GED test. First, I plan to become family counselor. And then I want to go for this course to be a phlebotomist. Well, I don't want to. I'm going to.
When I was resident, if you had angina, he gave a guy a bottle of nitro, and he popped the nitro when he had his chest pain, and after a couple bottles of nitro, he was dead. Because we didn't have bypass, we didn't have anything. We had nitro. Today, we have transplants, we have bypass, we have percutaneous interventions. It is phenomenal, absolutely phenomenal. So nobody doesn't acknowledge the enormous strides that medicine has taken. But if you really know your patients and you get inside their head and their heart, you learn things that you cannot learn unless you spend time.
And this is what we also want to convey to the young doctors, the importance of not only looking at the patient with a particular disease, but to look at his or her soul is much more than the problem of the body of the patient. It's what about their life?
His heart is failing, and at some point we're going to run out of options. We can only go so high on the medicines, and he doesn't understand that it's just a matter of when he passes, not if. He wants everything done. He wants CPR. We would put the breathing tube down, we'd intubate him, and it's not necessarily a nice way to die. The more humane option would be for him to go to palliative care and to die a comforting, peaceful death instead of this other way. But ultimately, it's his decision. You know, some people we can fix and some you can't, and you just do the best you can every day.
Amy yesterday tried to call his sister, I think 5 or 6 times. The first time she picked up and said she was going to the bank or something, and then called back in an hour, and then she just didn't answer the phone.
At least you're doing the best you can.
Yeah, I know.
Yeah. Okay, thank you.
You know, the Lord works in mysterious ways, and I feel better. I will be patient to see what is best for me. Yeah. This is the final encounter.
The big book over there.
So, what is next?
Yes, I am going home just to see my kids. That's the only reason why I want to go home. That's the reason why I want to go home. That's the reason why I want to make it. Right now, I'm a go lucky, ha-ha, smile type person. But before, if y'all would have saw me, y'all probably wouldn't even wanted to record me. Because my attitude was bad. My anger was, I was mad at the world. I was mad at everybody for no reason. I started to get over that after I felt like I had a chance to live. After I felt like I had a chance to live, all I had to do was fight. I'm like, okay, well, that gotta be a piece of cake. I've been fighting all my life. I've been fighting all my life to stay here. I've been fighting all my life. Being mad all the time, that's fighting. I've been fighting all my life. So if I could fight all my life for something stupid, then for something serious, you better put them boxing gloves on. Be ready for a couple punches, because it may happen, but I am gonna KO it.